Well, I would like to first off thank the organizers for the opportunity to speak with our audience today and contribute to this fantastic workshop with a presentation concerning a strategic approach to microsampling device selection and associated workflows supporting regulated bioanalysis. And the impetus for this topic really was derived from our experience with clients that know they want to leverage the benefits of microsampling to facilitate or enrich their clinical trials, as we've learned about in the previous talks, but that were uncertain about which device to proceed with in the absence of a strong ClinOps preference. And this is where the bioanalytical attributes of the targeted drug can assist in the choice of microsampler. And as we've observed in several instances at Altasciences, these BioA attributes can actually be the major driver for device selection. In terms of session content, I'm going to highlight some of the advantages and disadvantages of the most common microsampling devices that we've supported in our lab. And these include the Mitra, Capitainer B, and Tasso M20. We'll then consider three interrelated primary BioA challenges associated with dried blood microsamples, and then examine an experimental strategy that not only establishes method feasibility, but assists in actual device selection. I'll next introduce impact-assisted extraction as a device-independent sample preparation workflow that's proven to mitigate two of the three primary BioA challenges to ensure accurate and precise drug quantitation. And then we'll examine a couple of case studies which exemplify the relevance of the sampling substrate and strategies for overcoming matrix-dependent analyte instability. I'll start the device overview with that most historically supported in our lab, and that is the Mitra VAMS, introduced around 2015. I believe it was, maybe 2014, as a solution to eliminate the hematocrit bias on sampling volume, which it does exceptionally well. Its substrate is based on a proprietary hydrophilic sintered thermoplastic porous rigid polymer that's anchored to a plastic handler, making it straightforward to orient the tip with the surface of finger stick blood. The sampling is relatively quick, around 6 seconds, self-indicating, and the collected blood is dried quite rapidly in around 2 hours at room temperature in the presence of desiccant. Substrates are available between 10 and 30 microliters, and replicate sampling is facilitated by inclusion of a clamshell design that allows 2 or 4 collected samples. It is a direct-to-substrate sampling device, which on one hand eases the collection process. However, it can lead to occasional incomplete sampling or oversampling, and of course there is no tamper resistance pre or post sample collection. The next device supporting fingerstick collection that has garnered a lot of deserved attention is the Capitainer B, in part because it uses traditional cellulose media for which a plethora of published methodologies exist, given its early predominance as the material of choice for dried blood cards, and because its unique architecture incorporates an extremely accurate and precise microfluidic channel for the volumetric deposition of 10 microliters of blood onto Alstrom 222 pre-cut discs whose actual capacity is 20 microliters. It has a discrete sampling inlet, so it's not direct to substrate, and it is engineered with a waste absorbent that collects blood volumes that exceed the capacity of the capillary channel. So in this manner, one simply cannot oversample. Now, the entirety of the Capitainer B is housed in a foldable card format, and here I've shown on the left the outer and inner view of the device when unfolded. On the outside is the name of the product with a large area for labeling, and beneath that is where the lab accesses the DBS sample, which lays underneath the pair of vented flaps. The inside bottom of the unfolded card is where we sample a blood drop from a finger stick, and at the top there are clear sampling instructions which indicate to apply 1 big drop to the sampling inlet for 1 second. There are 2 sample inlets to allow for replicate sampling. One then waits around 20 seconds for the blood spot to appear in the translucent window, indicating successful transport to the discs. And back at the lab, we can access the microsamples from underneath those vented flaps. So mechanistically, how does the device work? Well, it controls the timing sequence of event by the thickness-dependent dissolving time of the thin dissolvable film, or TDF. When a droplet of unknown blood is applied to the inlet, the capillary microchannel fills to capacity while the TDF at the inlet starts to simultaneously dissolve. And once that inlet TDF dissolves, there's a breakthrough of blood to the waste absorbent below. And it's this breakthrough that causes a pinch off at the inlet of the capillary microchannel. The TDF at the outlet then starts to dissolve, and the microchannel volume empties through the outlet, facilitated by those capillary forces that occur during absorption of blood onto the cellulose disc. And I have to say that the Capitainer B performance is impressive, as our evaluations have indicated that QCs applied at the inlet in an excess of blood between 20 to 50 microliters in order to emulate study samples were well within acceptance criteria when quantified against a calibration curve that was introduced by positive displacement pipette directly onto the pre-cut cellulose discs. And if anyone is interested in the data from our evaluation of the Capitainer for quantitative BioA, please reach out, and I'm happy to pass that presentation from the AAPS along. Next up is the Tasso M20, which I don't need to spend much time on, as the previous talks have covered much of the device attributes. I'll just mention, for the sake of the slides that follow, that like the Mitra, the blood pads are a rigid porous polymer that are housed in a cartridge. However, there is minimal venting in that cartridge for the blood pads, resulting in a prolongation of microsample drying time. And under these semi-wetted conditions, in the presence of lysed erythrocytes, some molecules may exhibit instability. The good news is that a next-gen design is on the way, the T20, and it promises improved drying rates. Finally, unlike fingerstick sampling, which represents an opportunity to wipe away the first drop of blood before actual collection, the on-body approach simply does not allow that. So consequently, the initial volume of blood collected on the first blood pad will contain interstitial fluid. And so homogeneity relative to the remaining 3 sequential blood pads is compromised, and therefore we do not analyze that first blood pad from study samples. So that's an overview of the 3 most used devices supported in our laboratory, and even though they each offer volumetric sampling regardless of hematocrit level, there are other interrelated challenges for the downstream BioA. And these include hematocrit-induced recovery bias, where extracted analyte yields decrease with increasing hematocrit, as noted by Mano et al. From the ESI lab back in 2015. And this tends to be more predominant with the highly porous, rigid polymeric substrates due to increasing erythrocyte concentrations trapping analyte in the pores of the media. And because our internal standard is not on the sampling substrate, it cannot compensate for variability in the desorption recovery of analyte. In addition to decreasing recovery with increasing hematocrit, we've also correlated increased blood hematocrit with analyte instability for some molecules. And to convolute matters somewhat even further, an apparent analyte instability may actually be age-related extractability. That is, as the microsample ages, reduced analyte response is due to a loss in recovery and not due to actual instability. In which case, an alternative sample preparation workflow might be in order, as reported by Chi et al. From the Merck lab, where an initial direct extraction approach led to a 20% reduction in response for microsamples aged 7 days when compared to 24-hour storage. But When a more aggressive sample preparation approach was used involving vortex mixing, sonication, and liquid-liquid extraction, consistently high recovery was achieved between 24 hours and day 35 microsamples. I'll also note that in the ESI method, when they pivoted from vortex mixing to sonication, that narrowed the recovery gap between low and high hematocrit. Finally, to close our triangle, we have observed that as hematocrit increases, age-related extractability can become more pronounced, and therefore the age of the microsamples and the hematocrit level one optimizes extraction methodology on can have an enormous impact on assay success. In our experience, workflows that eliminate hematocrit recovery bias have also successfully eliminated age-related extractability, and we'll discuss that workflow shortly. So in light of the discussed BioA challenges, we need to consider a strategic approach to method development that not only allows for the elucidation of those mechanisms that can influence assay performance, but also aid in device selection. And to do this, we optimize our recovery experiments based on microsamples prepared in the following fashion. We use low and high QC concentration levels to determine linearity and response at hematocrit levels of 25, 40, and 55%, applied to both rigid polymeric substrates, that is the Mitra and the Tasso, and to cellulose, the Capitainer B. We then store those microsamples at -20, 4 degrees room temperature, and under conditions of accelerated stability testing at 40 degrees C and 90% relative humidity, with and without desiccant to differentiate temperature effects from humidity. We then define a reasonable storage time over which to titrate our recovery assessment as a function of hematocrit substrate and storage temperature, typically minimally 7 days and around 28 days by the time method development is completed. So with this experimental design, we can examine the interrelationship between hematocrit level, analyte stability, and age-related extractability, while also determining the role that the sampling substrate might play in either exacerbating or mitigating each of these occurrences. Now, in terms of sample preparation to determine recovery under each of the conditions in the experimental strategy, as mentioned, experience has taught that a technique which eliminates hematocrit recovery bias also eliminates age-related extractability. And this has been borne out by the successful implementation of impact-assisted extraction on over 15 validated assays, all without ISR failure. And here's how impact-assisted extraction works. As illustrated on the left, into a 96 well plate, we first place the microsample, followed by a stainless steel bead, and then we add extraction solvent containing stable label internal standard. We perform bead beating using a Specs genogrinder, and after exhaustive titration have found that 1750 strokes per minute for 10 minutes is optimal in the vast majority of cases. So why impact-assisted extraction as a workflow? Well, it was developed in response to overcoming recovery bias from blood hematocrit and changes in dried blood morphology observed with highly porous rigid polymers where analyte once again can become trapped in those pores by erythrocytes. And considering literature reporting that increasing extraction aggressiveness could mitigate the phenomena, then to our minds it made sense to increase the aggressiveness of extraction beyond vortex mixing and sonication to include multiple impacts of these rigid polymer microsamples with a suitable collision partner. The idea is to shear away the outer dried blood layers and to further compress the substrate upon impact, resulting in analyte desorption, followed by absorption of solvent upon reformation of the tip, much like the soaking and wringing out of a sponge. And this repeated compression reformation facilitates transport and solubilization of analyte from the porous substrate. What we have observed during impact-assisted extraction for rigid polymers is that the Mitra and Tasso substrates remain intact. That is, there is no homogenization, as is the case with cellulose. There are insoluble blood components observed at the bottom of the well, the extent of which really depends upon the extraction solvent and the number of impacts. And finally, it is an exothermic process that results in elevated well temperatures. as noted here. 45 degrees Celsius in the center of the plate, and 10 degrees or so less on the outer edges, which are less insulated. Now, if analyte stability is compromised at elevated temperatures, then we can pre-chill a cryoadapter and perform bead beating with that in place, or simply pre-chill the plate on wet ice and repeat between shorter cycles of impact, for example 2 by 5 minutes with a pre-chill between. And as we can see here, the temperature is reduced by some 20 degrees in the center of the plate, and it's more isothermal across the plate when using the cryoadapter approach. In terms of deconvoluting the role of aggressive mixing versus bead impact, the recovery of drug X here from 10 microliter metra tips by impact-assisted extraction at 1750 strokes per minute furnished complete extractability at each of 40% and 55% hematocrit after 10 minutes. When we repeat the experiment in the absence of the stainless steel bead, but at similar extraction solvent temperature, that is 45 degrees, we observe a reduction in recovery greater than 20% at 55% hematocrit, confirming the importance of bead impact in the proposed mechanism for overcoming hematocrit bias. As an example, compared to sonication, we compared the recovery of naproxen from metra under optimized conditions as a function of blood hematocrit from 0%, that is plasma, to 63%, a bit extreme, but to exemplify differences. And we conclude that both consistent and high recovery by impact-assisted extraction is achieved independent of hematocrit, while decreased recovery with increased hematocrit is observed by sonication, despite a 6-fold longer extraction period. Another example of impact-assisted extraction performance, and one which was chosen to gauge the universality of the technique, involves a panel of 16 anti-epileptic drugs of rather disparate log P, ranging from 0.11 for zonisamide to 3.42 for desmethylclobazam. Under optimized impact-assisted extraction conditions of 10 minutes at 1750 strokes per minute in 80% methanol, preceded by a brief aqueous pre-soak, we observe an average recovery for the 16 AEDs greater than 90%. In terms of hematocrit evaluation, we see in this compilation that precision and accuracy data for low and high QC samples at hematocrit levels of 25 and 55% met all acceptance criteria when back calculated against a curve at a median hematocrit of 40%. So not only have we achieved high yields for all 16 anti-epileptic drugs using impact-assisted extraction, but we've also eliminated any potential risk of hematocrit-induced recovery bias had we used a less aggressive sample preparation workflow. Okay, let's now turn to a case study that highlights the relevance of the sampling substrate, and initial work on the metra for this molecule under optimized impact-assisted extraction conditions demonstrated an average negative 20% concentration bias for stability QCs between 7 and 28 days of storage at room temperature in the presence of desiccant, and that was regardless of hematocrit level. However, at reduced temperature storage, acceptance criteria could be met, so we ruled out age-related extractability. Now note that freshly prepared metra calibrants used to determine stability QC biases were stored at 4 degrees C for 24 hours, and recoveries were approximately 85%, again independent of hematocrit. So the totality of this data suggests a kinetically driven process for degradation given the temperature-dependent response loss. However, we established 8 hours of stability in whole blood and 5 hours of stability in hemolyzed blood. And I'll just note that hemolyzed blood stability can be a useful diagnostic as RBCs do rupture upon drying, and analyte is in a semi-wetted state for a brief period in the presence of those intracellular components which may play a role in drug transformation. So given the liquid stability results, one must question the sampling substrate, and therefore we repeated our 28-day experiment at room temperature and 4 degrees C on DMPK-C, which is an untreated cellulose substrate. And I'm just simplifying the results table here with data from high concentration stability QCs And as observed, stability was achieved on the DMPKC substrate at both room temperature and 4 degrees C. So now the fact that we have stability on cellulose substrate allows us to conclude that the drug is chemically stable in dried blood matrix, and therefore the room temperature metra results are not matrix dependent, but rather substrate specific. And further evidence for that can be seen if we sample the analyte in methanol versus plasma versus blood. And here we observe a decreased response loss with an increase in substrate shielding by the matrix components, by the increase in matrix components as we go from methanol to plasma to blood. I'd like to just point out that this work was conducted prior to Capitainer B product availability, but most certainly these results were an impetus for screening cellulose substrates early on in the method development process. For the next case study, the challenges were rather different and required an out-of-the-box solution. For this analyte, we observed reduced recovery, some 42% on both Mitra and Capitainer, so they mirrored each other over a 24-day period, most pronounced at room temperature, which I've plotted here, but improving somewhat at reduced temperatures of 4 degrees and minus 20 degrees C. However, our client insisted that reduced temperature storage over a truncated period in order to meet acceptance criteria for stability was not an option for this study, and so we were tasked with make it work at room temperature. Now we know historically, once again, that impact-assisted extraction results in consistent recovery independent of hematocrit and is immune to age-related extractability. And so when we see trends like this on both media types, matrix-induced analyte instability must be considered, and this conclusion is supported by the additional observations of a negative 15% response bias in proceeding from 25% to 55% hematocrit, indicating RBC involvement towards instability. As well, a matrix effect evaluation for both the Mitra and the Capitainer revealed that 4 out of 6 donors resulted in a negative concentration bias outside of acceptance criteria for both low and high QCs. Donor 6 was used for calibrant preparation in this data. And finally, although 5 hours of whole blood stability could be established, only 1 hour was achievable for hemolyzed blood. So given the structure of the analyte in this case study, which fortunately I cannot divulge the full structure other than to say it's a singly halogenated fused ring system with a primary amine, we proposed oxidative deamination to the ketone as the major degradation pathway. And therefore we evaluated the pretreatment of the Mitra substrate with an aqueous solution of 1 molar ascorbic acid and dried the tips for 24 hours in the presence of desiccant. Now, this reduces the sampling volume by about 13%, but it does not impact the sampling rate, the wickability, or the precision and accuracy of blood collection. I'll also make note that at the time that these experiments were being conducted, we did not attempt to pretreat the Capitainer due to concerns regarding potential dissolution of that thin dissolvable film, which would therefore foul the device performance. But my understanding from recent discussions with Capitainer is that they will pretreat the cellulose discs prior to device assembly. When we now overlay the pretreated Mitra with that of untreated Mitra and Capitainer, we observe some response loss up to 6 days, around 10%, which then levels off and is consistent for up to the 75 days evaluated within method development. In this example, defining recovery as a function of storage time aids in defining the guardrails of the assay in that we understand freshly prepared calibrants and QCs on pre-treated Mitra should be aged 6 days prior to being used for sample analysis to emulate that initial response loss. In terms of hematocrit bias, we observed originally a negative 15% bias from 25% to 55% hematocrit for untreated Mitra when stored at room temperature for 7 days. However, on pre-treated Mitra, we could demonstrate 21 days of stability at room temperature when combined with 8 days of accelerated stability testing at 40 degrees Celsius for both low and high QCs. In comparing matrix effect for untreated versus treated mitra, those donors previously exhibiting a negative concentration bias are now back calculating within acceptance criteria. And just to highlight some actual validation data, one critical aspect of a pre-treatment approach in microsampling is to establish the shelf life of the modified substrate. And here we see that mitra pre-treated with 1 molar ascorbic acid stored 154 days at room temperature in the presence of desiccant conferred 147 days of blood microsample stability, as indicated by the very tight statistics here for our low and high concentration stability QCs. The validation results for between run precision and accuracy exemplified here for 3 batches containing 6 QCs per concentration level, and each batch also sailed through in meeting acceptance criteria. And the calibration curves from 5 batches used to support validation assessments and sample analysis also met all acceptance criteria with a mean correlation coefficient of 0.9949. So at the end of the day, a very robust assay, fully validatable and able to support study samples. Now, in that case study, given the results of increased analyte instability with increasing hematocrit on untreated mitra, an alternative substrate pretreatment might have been membrane filtration of those RBCs. And had the SEP10 device been available 8 months ago from Capitainer, that might very well have offered a more simplified approach to mitigating analyte instability for this case. And that would have resulted in a dried plasma spot approach for microsampling. Most certainly our lab will be having a close look at this recently introduced technology, understanding its attributes and comparing the mitra pretreatment approach to that of RBC filtering as it applies to analyte instability when there is a evidence of erythrocyte involvement to that drug transformation. So to summarize then, in the absence of a strong ClinOps preference for a given microsampler, the BioA attributes can represent a major driver for device selection as we've seen today. However, the development strategy, not only for the feasibility of microsampling, but the actual device selection itself must include a thorough characterization of the relationship between hematocrit, substrate, age-related extractability, and analyte stability. And finally, impact-assisted extraction as a sample preparation workflow has demonstrated its universality by successfully supporting each and every application that it has been applied to in our laboratory, eliminating hematocrit bias and age-related extractability with recoveries typically in excess of 85%. I'd like to acknowledge my colleagues at Altasciences who have contributed much to the success of the programs that we support and that continue to progress novel workflows to overcome the unique BioA challenges that we face, expanding the applicability of microsampling. Thank you all for your attention.